So I'm going to turn the floor over to Hannah, and Hannah can introduce herself. I met Hannah at the ACT conference.
So I wanted to just talk a minute about the advantages of training couples therapists to do sex therapy. So the basic advantage is that it minimizes the complexities of changing therapists. Once you have a therapeutic relationship and the therapist says to you, oh, you mentioned sex and this does happen, I need to refer you to a sex therapist. So then you come up against, so why is that? Is sex not a part of the couple's life? You know, what does it mean that you're referring me? You can't work with this? So, and the other thing that I come up a lot with is it's confusing for the person, because what are they talking about to whom? And now the sex therapist has to take a whole history that they've already worked on, and you know, so it comes transferring, unless you have to, unless there are certain situations where the deeper work really needs to be done by somebody who's well familiar with the deeper dynamics of sexual dysfunction. But, you know, unless that's the situation, a couples therapist can do this work and should be doing this work. So it belongs together. And I'll just give you an example of a consultation I did recently. A couples therapist who had worked for years and did incredibly wonderful work, working individually and with the couple together. They had come from really difficult backgrounds, and her work was top-notch. But although she talked to them about their sexual relationship, it didn't move. And so she referred them to me, and I thought, I don't want to be repeating the work that she did. I'm going to do something different here. And I sat with them, and I listened to what the problem was. And the problem was that the husband had a very strong drive to have sex often. And what it meant to him to have that touch and that experience is that he was loved and he felt secure. And his wife felt if she didn't feel desire when he felt desire, how is she going to make love with him? That doesn't make sense. And so there was this ongoing aggravation. I did a very simple intervention, which I'm going to teach you. I did a little bit of psychoeducation. I said to her, you know, one of the things that we've learned has to do with the sexual response cycle. It used to be thought that it was the same for men and women. It's not the same for men and women, although between us there's now research going on to show that maybe it's not that different. But I said to her, it's not the same for men and women. For men, it begins with, they have a desire, there's excitement, the excitement builds, you orgasm, there's resolution. For women, it's more complex. Women don't always have spontaneous desire. For women, most often, especially in longer-term relations, there's responsive desire. In other words, the sexual response cycle is willingness, and then there's arousal and excitement, and then it builds, and then there's orgasm. The rest of it is the same, but it begins with willingness. Desire can come up at any point in those cycles. It might not come up till after orgasm. And then the woman might feel, you know, I want more. Or it might come up during arousal. But it's not going to start. A man will start with desire, but a woman's going to start with willingness. And willingness is connected to motivation.
To what?
Motivation. Why do you want to make love? Right? So you know, if the motivation comes from a place of, you know, I love my spouse, I love my husband, he wants this, I want to please him. So that's fine, because the desire will come up at some other point in the cycle. So when she heard that, she said, so you mean there's nothing wrong with me? because she was under the impression that because she didn't have spontaneous desire so often, there was something wrong with her. And once she got that, then I sent them back to their therapist. And that was 2 sessions of work. So, having to repeat the history is an awful thing, I think, if necessary, but where it can be avoided. So what do couples therapists need to know to work with sexual concerns? You need to know how to ask, how's your sex life? And be able to listen to the response. And you need to be able to do it comfortably. So that's, whatever.
That's a good question. So you're not asking about intimacy, you're just asking about the sexual part.
Well, what do you mean by intimacy?
Intimacy is something that connects you, or connects the person to another person.
Yes.
The sex is a separate part unless it's together, you know what I'm saying?
So the relation, in other words, you're not, what I hear you saying is you're not asking about the relationship. Yes, you're gonna ask about the relationship also. Yes, but here you're gonna start with how's your sex life, because it's much easier for people to answer questions about relationship than about sex.
Intimacy involves the sexual part also.
I'm sorry, say it again?
The intimacy part is also sexual.
Of course, yes. And in a minute, we're gonna talk more about that actually, and how that connects to healthy sexuality.
One question, are you gonna deal with when you ask that question?
You ask that question when you're doing an intake, when you're first
really?
getting to know the person.
Oh, wow.
Yeah, as you're asking about what they're struggling with, you say, and how's your sex life? Right at the beginning.
If you're presenting as a sex therapist, but if
No,
you're presenting
just as a
couples
as a couples
therapist, you ask this
therapist.
question
You just ask.
as standard.
Yeah, I mean, you're, yeah.
Now, I just find it's easier actually when you're
Kind of
doing
very straightforward.
an intake and you're doing it almost generic, how's your sex life, then it doesn't sound like inquisitive. I find couples have an easier time answering that question a little bit as you're doing it as an intake because it's
Right.
almost
It's also straightforward.
It's also straightforward. It's information and
That's
not right. So
And it's important information.
Yeah.
I think yeah.
And then you need to know sexual anatomy and physiology. You need to know about the sexual response cycle because sexual dysfunctions are going to be very tied into the sexual response cycle, and you need to know basic interventions. So the other thing you need to know is you need to have some theoretical conceptualization of what healthy sexuality is. What's a healthy sexual relationship? So McCarthy, I like their model. It's the good enough sex model, like Winnicott's good enough
Yes.
mothering,
Yeah.
right?
Beautiful.
So they write, healthy marriages are satisfying, secure, and sexual. 15 to 20% of the role of sexuality, and this is really important, is to energize the couple bond and reinforce feelings of desirability and vitality. Sexual energy is life energy. And the paradox, they said, is when you have sexual difficulties, it can destabilize the person and it can threaten the stability in the marriage if not dealt with. They talk about the developmental challenge for new couples, but it's not just new couples, it's the couples that we're working with. But they explain that most couples begin in a romantic, passionate idea, everything is like wow. And
What page are
this
we on now?
generally lasts 6 months to 2 years.
Yeah, she's not-
The
I got it on you.
the challenge after this phase, this first phase, is to develop a couple sexual style that promotes strong, resilient desire. And many couples they're not aware of that, and that doesn't happen. And
They're not aware of what.
they're not
The
aware of the
importance
importance of creating a way to be together sexually on a regular basis that's pleasurable.
After the 2-year period where everything
Yeah,
dies
once you
down a
move,
little. Okay.
once you move out of that, what he calls the limerence phase. And he says the vulnerability for traditional couples, for married couples, is treating sexuality with benign neglect. You cannot do that. Even if sex is functional, if it's just, you know, it's happening whenever there's time for it to happen, there's not energy put into it and into the relationship. Even if sex is functional, it is not vital or special. And because it's not vital or special, it does not reinforce desire and satisfaction. And that's really what we want to help couples do, is develop a style where they look forward to lovemaking, where they want to be together, where they're happy. And that's also so, you know, in our frum communities where this, you know, first 6 month to 2 year romantic phase doesn't exist because it's, you know, they're arranged marriages and it's done differently. But it's the challenge for all couples to develop a sexual style that promotes desire, vitality, excitement of being together, in and out of the bed. So they tell us that sexual desire is enhanced by positive anticipation, right? Something to look forward to, by choice. There has to be choice. Open communication. Desire is sabotaged by pressure, performance demands, and predictability. If it's the same, that's not so good. As a matter of fact, I mentioned Bill O'Hanlon before. So I remember Bill once said, if you have the same problem after the same problem, you have a problem. But if you have a different problem, after another problem, you're okay. You know, so it's a similar, predictability is,
There's always going to be problems.
is a problem. So
Pressure,
sexual
predictability, pressure, what else happened?
pressure and
Performance.
performance demands,
It's on
which
the-
are, you know, that you must have
It's on your
intercourse.
Oh,
You must have intercourse. Without intercourse, it's not a sexual
Okay,
encounter.
that's not pressure.
You must have orgasm.
Mhm.
That's another one. We're going to talk about that. So there needs to be mutual consent. There needs to be a focus on sharing pleasure and not this perfect intercourse performance or demand performance. And, okay. So now we're going to take a look at some interventions to begin to formulate ideas of what needs to be done, you know, do an assessment of where the couple is in terms of sexuality. So Robert Sternberg's triangular theory of love,
It's on page 4.
or it's called the three-legged stool, and there's a picture of it. So Sternberg says a healthy relationship, a healthy marriage, has to have 3 components. It has to have intimacy, right, the emotional connection. It has to have commitment, and it has to have passion, the sexual connection. If you have all 3, your three-legged stool is going to be stable. If you don't have all 3, then it's not going to be stable. And here he talks about, you know, some ways that you don't have all 3. And, you know, one of the easy ways when you sit with a couple and you listen to them, you begin to hear the issue, is to think about this. What do they have? Do they have commitment? Do they have intimacy? Do they have passion? Do they have a sexual relationship? And you begin to get an idea of where you're going to need to intervene. Just in this quick picture, right?
Romantic love puts people on a sort of a high as well.
Yes, it does, but it doesn't last.
Right. But it does give you that high and could cloud a person's judgment also.
Yes, that's right. That's why in Hollywood, I don't know so much in Israel, but you see, you know, these you know, performers, right? They're married and 6 weeks later they're divorced because there's no commitment.
Can I just ask a question? Sorry.
Yeah.
Just to clarify, this point doesn't have a title? I just
Yeah,
wanna
it
clarify.
does.
Is there just
Commitment, passion, that's intimacy on top where
It's
you don't see
intimacy.
the word.
Ah, oh, got it.
That's
Thank you.
intimacy. So if you have just intimacy and commitment, but no sexuality, no passion, so you're gonna have companionate. You're good companions.
You're good friends.
Yeah. If you have passion and commitment, but no intimacy, it's an empty kind of a love. And if you have passion and intimacy, then you have romance. Now, not to say that romance isn't a really important part of a sexual relationship and a couple's relationship. It is. And we can talk about that. But, and so they're all important. You want to have companionship, you want to have romance, you want to have commitment, right? But looking at, that's one way of taking a quick picture of where do I need to work, what's missing. So there's another model that is really useful. Have any of you heard of the implicit model? Oh, good, okay. Yeah, so let me tell you about the implicit model. So Jack Annon, who was a clinical psychologist, a forensic psychologist, and a private detective in Hawaii. So I'm thinking he must have worked on a lot of couples issues.
In Hawaii.
Put together this model, and he said this is a format that couples therapists can easily use in working with sexual issues. And his motto for the format was start simple and do only what's needed.
That's very good advice.
And it's good advice for everything, right? Start simple and do what's needed.
Don't overcomplicate.
And there are 4 levels of intervention, which is what the letters stand for. So the P is for permission giving. LI is limited information. You just give information that's needed. SS, specific suggestions. And IT, intensive therapy. So those are 4. You go from one to the next. You start at 1. If that's enough, you stop. You add as needed. So permission giving is when you meet the couple, you want to hear what the problem is, identify the problem. You want to validate the couple for coming to see you, coming for help. You want to provide hope that therapy can help. And you want to normalize the concerns because the concerns are often something's off. So you want to normalize, you want to say, this is a concern that a lot of people bring into the office. And very often, what we see is sometimes just giving a couple a chance, permission to just talk about what is.
Yep. In
the talking about it, it's resolved. And that's enough. Where it's not enough, we go on to give information, that's specific to their concerns. So we'll do psychoeducation about the sexual response cycle. We'll do education about how the body works, how the sexual system works. So we're going to inquire. It's not we're going to bypass, we're going to inquire about medical history, about medications, about, when did it start, how is it affecting the relationship, what have they done about the problem. So we're going to explore, but we're also going to say, especially if we have a sense, that this is about anxiety. And, that when the man gets anxious, and this is really Masters and Johnson's work, if he gets anxious that he's not pleasing his partner enough. And, there are relationships where a woman can be very demanding and very critical. And vice versa, So there's anxiety, so you can do some psychoeducation where you say, what happened? So we need to deal with the anxiety, right? So you're going to give information specific to the concern. You're going to correct any myths or misinterpretations. So I'm going to give you an example that I worked with a couple, and this was a misinterpretation, but fascinating. It was the first time I'd heard it, where there were a lot of problems from the beginning of the marriage. He was forced into the marriage. She was desperate to escape her home. This is a Hasidic couple. And he did not want to get married. And he wasn't ready to get married. He didn't have social skills, and he was lacking in many areas, that there were many problems. But I had worked with him individually, and his wife had worked with an individual therapist, Labria. That's how the treatment started. And I referred them at a certain point to a couples therapist. They didn't like him, but he had developed a therapeutic connection with me. And he had sexual abuse in his history, and part of why he connected so powerfully is because I said to him, you know, in doing an intake, were you ever abused? And he broke down in tears. So that was a. So anyway, they made some movement, and then in one session he said to me, you know, we're always fighting about making love. She always want to make something. You know, I don't want to make love. It's so much work. I said, oh, what's so much work? So he tells me, how, you know, I said, what's so much work? How are you making love? So he tells me the way that they make love is that she tells him what to do to pleasure her. He does that, and they're done. I said, okay, and what about you? He said, well, I don't matter. It's written in the ketubah that a man has to satisfy his wife sexually. It doesn't say anything about the husband. So that's a misinterpretation, right? That needs to be worked with. So
How did you respond?
well, I said to
Without
him,
without.
practice. You know, work on yourself, and you can stay centered and focused on the client. And I said to him, you know, that's so interesting. You're right. It does say that on the ketubah, but it's understood. It's understood. And I said, you can check it out with your Rav if you want, but it's my understanding it's understood that pleasure is for both. Misameya chatan v'kala.
They're gonna have children.
They already had children
Yeah,
because they're
but-
having sex, but he doesn't like it. When she's ready for intercourse, she says, okay, now. And so they have 2 children. So, you know, and I said to him, you know, what would you like? How would you like to be pleasured? So he was able to think about that, and he was able to say some things. And I said, you know, you really need to go and back and talk to your wife about this, that this is for both of you. And he was surprised to see that she was so happy and relieved that he finally told her something that he wanted. And so that did make a difference, you know, in his experience with her. And also during this phase, you want to make an assessment of, you know, how resilient is the couple? How much leeway is there really here to make changes? And based on what?
You have to know the couple.
You have to, right.
Right, you have to
Right.
get a good sense of that.
What do you,
Right,
what,
so-
okay, help me understand that a little better.
Yeah, which,
Resilient enough to know your couple to so help me, I mean, because that's
if
some
you
broad
have a
term.
couple that
Oh,
you're working
so
with,
resilient.
and you make an intervention, you make an interpretation, you explain something, they can hear you. They look at each other.
Right.
They find it's interesting, or they have something to say about it. You know that you're working with
connect.
somebody where there's space to work.
Ah, okay.
But if you have a couple where the husband says, or the wife says, that's ridiculous, but you need to have buy-in, you know, how will this be for you? Do you feel safe doing this? You know, this might be the next step. Is that okay? Can we go there? And you have to process whatever assignment you give. You have to ask them, how was it? Did they do it? Did they not do it? What was it like? Right? So I remember one man said, you know, I really liked it when she touched my hands. I didn't like it so much when I touched hers. You know, so that already gives you some information that he's not so much of a giver. He likes to receive, but he's not so much of a giver. You know, begin to work with all of that. So specific suggestions, depending on the problem that the couple brings in, you know, helping them find time to prioritize the relationship, going out once a week, once every other week, where they get dressed up like when they were dating, where their full attention is on each other, where they do something pleasurable. It's not all about the responsibility and the children. For some couples, they like to play games. You leave the kids at home, we don't have money to really go out. What are we playing? Changing the surroundings in a space can be useful. I remember one couple that I worked with where the wife said, if we're in the kitchen cooking together, I get turned on. And then when we go to the bedroom, as soon as I cross over the threshold into the bedroom, I don't want to make love anymore. So that was a whole piece of work. But part of what we did with that was I asked her how it would be for her to redecorate the bedroom. New curtains, new sheets.
Put a stove in.
Maybe, if needed.
Yes.
The work
and that
together
can-
on building the home, doing something homely.
Well,
Right,
maybe
together,
decorating.
shopping
I
together.
sent a couple
Decorating,
off
but in
to
the
buy
bedroom
sheets
setting.
together.
That's right.
They couldn't agree, but they finally did agree, and because it was a big issue, the sheets, they went off and they actually did it. They spent a long time arguing this and that. By the end of the day, they came home with sheets.
And did they like them?
He really did. She's getting used to them, but the idea that they went together for this
Right.
purpose was very big for both of them.
So this is
They have a hard time getting along, but that was okay. They did it.
So this was actually a very good experience for this couple. The pleasure wheel is a nice experience to do with couples. I found it really effective. There was a lovely couple that came into me in their 50s. Their kids were already grown, and they were both very established in high-level careers, but their lives had become parallel lives. And although, the husband had an interest in having sex, his wife said, done. So one of the things that I started with was pleasure. And I had them each do their own. You make a circle, you divide it up into pieces like a pie, and each of them wrote on their pleasure wheel in each section an activity that was pleasurable for them. And I gave them, and we talked about this, and they were a little surprised about what was on each other's wheel. And the assignment was once a week to alternate doing something on their wheel and once a week on the spouse's wheel. And through doing that, they were again able to reconnect, and then we could work on the sexual relationship and what that was about. Simmering is something. Steve Snyder has a wonderful book, Love Worth Making, easy to read. So Steve talks about simmering. He says one of the things that teenagers do really well, I don't know if in the frum community so much, probably less than in the secular community, is they're constantly texting each other. I'm so looking forward to seeing you later. I'm thinking about and he calls it simmering. It's like you're letting the other person know.
Do it sticky now, it's people don't think
Yeah,
it's sticky.
they're excited to see them later on. So you do something that's suggestive and without having to be sexual, but suggestive that later if we want. So pacing I already talked about, what would feel safe, it looks like the next step, processing, intensive therapy, right? So that's the IT implicit. So, you've worked with a couple, you've gone through limited information, you've gone through, but it's not going anywhere. So that's an indication there are deeper issues to be looked at, and Anon said, implicit, refer to a sex therapist who can help the client with these deeper underlying issues. However, I don't know that you need to be ASEX certified. I am ASEX certified, but I think, as couples therapists, you take trainings, you work with people, you have supervision. You can, learn to really go into deeper underlying issues. So,
What would be a deeper underlying issue?
Yeah,
I mean,
wondering
help
what
me
you're
understand.
referring
okay,
Sexual abuse?
to. That's what I
A sexual abuse,
no,
we should
I'll
be able
give
to
you,
work
well,
on.
connected a little bit to that. I'll give you an example of a deeper underlying
Yeah.
issue. So I worked with a Visionist couple, young people, they had 4 children. And the issue was that the wife had pain with intercourse. But it wasn't always. It only happened sometimes, which became a puzzle. Why sometimes and not other times? So one of the things that I did with her is, and that's why I think it's important to know, just talking doesn't always take you to a deeper layer.
Just what?
Talking. When you see you're not going deeper, you want to try something different. So one of the things that I tried with her was I tried the empty chair with imagery. And I said to her, you know, is it okay to use the imagination? I said, I want you to imagine that you can take the pain that you feel on having intercourse and put it in the chair over there. It is what it is, but let's see if we can get to know it better. And she was agreeable, and I said to her, can you see it in the chair? And she said, yes. And I said, what does it look like? And she said, it looks like an arrow with thorns covering the longer part of the arrow. Can you picture this? Right, so there's the arrow, right, with the point, and then there are thorns coming out of the part that goes into the bow. And we talked about that, and I don't remember the specific dialogue, but what came out of it was that she had a fear that having intercourse could damage her. And sometimes that fear, and that's a whole other area to be explored, was stronger than other times. So I stepped in with some psychoeducation, but as we worked, what ended up coming out was that she thought that she had been sexually abused by her father, who she knew had sexually abused her sister and another relative. She didn't have memories of it.
It's
didn't-
very hard when they don't have
Right, she didn't have memories of it, and she said, is it really important that I uncover those memories?
memories. Yeah.
And I said to her, no, it's not really important that you uncover those memories. What's really important is, how is this impacting you now? And how do we begin to work with it so that you can feel more secure making love? So that's an example of a deeper issue.
Okay.
Can I just ask a question? All this work that you just described was done with her husband in the room?
That piece was not with her husband, but I would have done it with her husband. I do this kind of work with both in the room.
On that particular occasion, just
She happened to come by herself that time. Her husband couldn't come.
and
But
you don't relate it to the fact that she was able to speak because he wasn't there. Sometimes
don't-
some things are easier with or without. You always,
you know,
both of them.
I tell you, it's very interesting. You know, I worked for a number of years, one day a week, at the Muncie Medical Center. And part of the time I did supervision, and part of the time I did sex therapy with people from the Haredi communities. And I was surprised to see how open. Yes,
The ones there in the room.
in the room.
Yeah,
Yeah, together with the spouse, by themselves. The only ones who were not open were the ones who hadn't really developed a voice. You know, Schnarch writes about differentiation, right? In order to have a good sex life, you have to have two differentiated people who are well regulated, who can, you know, be in their own shoes and the other person's shoes without getting reactive. It's a challenge. So there you won't have as much openness. There you have to work on first developing voice. First learning to speak M. This is how I talk to them.
Ever, as a rule, find it appropriate to ask the couple, let's have one session just with you or just with you?
I will separate, not because of the content to be talked about. I will separate where I feel there's a personality issue
Yeah.
that's getting in the way of the work. And I want to see how that works. So an example of that is a couple that I saw whose kids were already grown. They just had one teenager at home. It was a terrible marriage. The husband was very into himself and what he wanted, and when he didn't get it, he went into rages. The wife felt very dependent. She came from a very poor family. Here there was money, comfortable lifestyle. So I suggested to them that I worked at the beginning with each of them individually for a little bit and then came together. And then I worked more with him individually. And that was helpful. And I did a lot of visualization. I did a lot of empty chair work with him. I did a lot of focusing on the body. Notice your body. He was totally dissociated from his body. Teaching him how to notice sensation in the body. Non-verbal kinds of, non-cognitive rather than non-verbal. So I'll separate for those reasons, but I won't separate because of the content. Because they're going home. This is their life. Right?
I think if you get, again, giving them permission in a place as a therapist to talk about things that they've been uncomfortable talking about opens up a whole lot of dialogue between sessions.
That's right.
And even when somebody struggles with something that makes them very vulnerable, that's exactly what I want them to be, their partner to be able to see.
That's right. Exactly.
Because then they'll have empathy for it.
Well, then, or we might have to help them. This man needed
Right,
to
exactly. I mean,
develop it.
if or you can help them develop. And notice
Right.
that it doesn't sound to me like that you really understand your husband's or wife's struggle around this. Can we talk about that? And then the other person can hear that that's why they're not getting the empathy and
That's
back
right.
and forth. So I
Absolutely.
think it's much better.
I agree.
So then I like what you're doing.
Thank you. So the other thing under intensive treatment is it's really important to keep up with the research. So this was a very interesting piece of research that came out of Canada. Natalie Rosen and her colleagues in Montreal did research on heterosexual women who had pain during intercourse. And what they found was the partners of these women who said to them, well, let's not do anything then if it's going to hurt you, versus the other group was partners who said to the women, you know, honey, let's not do anything that's going to hurt you, but let's figure out what we can do that will be pleasurable and that won't hurt you. And that the women had much less pain over the long term when they started to have intercourse than the women whose partners said, let's not.
Okay, help me. You said the people that adapt and then find a way to discuss doing something without pain, or the people one that keeps on going?
Without pain. No, where they keep on going, that's a problem. You
Okay.
cannot keep on going.
Okay,
so long as
no.
it's-
That's I thought so. Okay, so I misunderstood. Somebody says, okay, let's figure out what we can do together.
That's right.
Okay.
That's right. Let's figure out, maybe we can, here's a repertoire of sexual activities. Which of those can we do? So tools for uncovering beliefs and attitudes, right? These are the deeper, right? They're unconscious and contribute to sexual difficulties. So how do you make them conscious? So we've talked about, the guided visualization, imagery, the empty chair, if a body experience, what do you notice in your body? You know, I notice that my heart is beating 100 miles an hour for a minute or whatever. So if your heart could speak right now, what would it say, right? Is an opening. Reflecting on an unexpected body experience can be very powerful. You know, a lot of people that come in are really not connected to their body. They're not used to paying attention to their body sensations. So I do a lot of teaching about that, a lot of work with that. And one woman came in one day and she said, you know, I was cut off by a car and I noticed that I gasped and my body got very tight, right? So that was, and then she was able to talk about that, and it allowed for deepening of that work for her to really now believe that there was validity to paying attention to your body and body sensations. So anatomy and physiology, right? We need to have the correct language to be able to talk about the sexual system, sexual behaviors. I like Steve Snyder's metaphor of hardware and software. Hardware is the physical makeup of the sexual system, and software is the psychological, relational, or situational aspect. You know, and even as the computer challenged among us knows, so I'm computer challenged, there can be problems with either the hardware or the software. So I think it's a great metaphor to think about. So the sexual response cycle, so that's really important to know about. So the sexual response cycle has evolved since Masters and Johnson's. And it really reflects the different ways of thinking about sexuality and sex therapy. So it began with Masters and Johnson's. Masters and Johnson's did research. Out of all of that research, what they discovered or what they conceptualized was that there is a universal sexual response cycle. Here's how it happens. First there's desire, then there's arousal, excitement, orgasm, and resolution. And so this is a picture of how that happens, that, you know, excitement builds. I don't know why he says plateau. That I never get, because the excitement continues to build to orgasm. And then there's resolution. And Masters and Johnson said anybody whose sexual behavior differs from how it should be in these cycles has a sexual dysfunction.
That's horrible.
So, and that became actually the basis for the DSM. If you look at the diagnoses in the DSM, they're according to the sexual response cycle. And so they linked anxiety. They said, look, anxiety is the big problem with sexual dysfunction in two key areas. One is there's a preoccupation with pleasing the partner so that you're not paying attention to your own body and you're not flowing with your body's energy where it's taking you. And the other is that there's excessive self-monitoring, of watching yourself perform, spectatoring. And so the treatment mostly that he used, you know, was sensate focus, although he also used stop and start, you know, but behaviorally based treatments, symptom focused, and he wanted to alleviate the symptom, restore functioning, and you're cured. Now, what's interesting about Masters and Johnson is they worked, at least initially, very differently. You know, we see couples for 45 minutes, an hour and a half, once a week. They had intensives. They would have a couple come to them for 2 weeks and stay in a hotel and work with them every day and use the partner as a co-therapist. So, you know, it's interesting to, you know, to read about their work. So Helen Kaplan was a very interesting woman. She was a gynecologist obstetrician. She was a psychoanalyst. She was a Holocaust survivor, came from Germany. She also had 3 marriages and 3 divorces. And she was a smart woman. She was petite, she was outspoken, she was fun to study with. And she added desire to Masters and Johnson's sexual response cycle. She said, no, it starts with desire, but she kept the linear structure. So desire was always spontaneous desire. But the one thing that she did recognize was that desire disorders, unlike the arousal disorders, the orgasm disorders, the desire disorders were very hard to treat. People were not responsive to behavioral interventions for desire disorders. And Helen really believed in bypassing any relationship issues or any deep emotional issues if possible. Do the behavioral exercise, get better, move on. But with desire disorders, you couldn't do that. You couldn't do that with desire disorders. And she recognized you really needed to have deeper psychological treatment for desires. You needed to look at thoughts, you needed to look at motivation, you needed to look at fantasies.
No, I'm actually talking about someone not married, as someone who's like.
Oh, you talked about
Yeah, I
that.
did too, but it was at a wedding. I told you. So,
That was true.
yeah. And calls herself asexual. She doesn't have any fantasies.
Asexual, yeah, that's a newer.
I know.
One of the
And
newer gender.
but sort of wants to be okay with it because it's very. Is it a dysfunction or?
Well,
can
why
own
is she
it?
not okay with it?
She actually is, but she hears the whole society talking about sex,
And she's
and
not
she's
into it
like
at all.
not interested. Like
So here's the thing
yeah.
with these asexuality. I did a paper on
Oh, you
asexuality.
did. Well,
Ah,
Great.
there you go, Sharon.
Asexuality is on a spectrum, right? You
Okay.
have the bell curve,
yeah.
right? So there are some asexuals that they do have. It's fun for them. They have pleasure when they have sex, but they're not particularly motivated to pursue it. And then in the middle, you have people who, they're not particularly interested, but if their partner wants, it's okay with them. They're happy to please the partner. All the way to the other extreme where there's no interest, I'm not doing
There's
it.
repulsion. Is there such a
No,
thing?
no, it's not repulsion, just not interested, and my partner's interested, and, well, she'll leave me, so I'll get another partner, and, whatever. It's not clear to me, how much of that, although some people who say they're asexual have been checked out hormonally, and the testosterone levels and are fine, the androgen levels, but I don't really know.
Oh, yeah.
I don't really know, but there's a range, and, it might be interesting for her to see where she, rather than think she's not okay, see where she is on range.
I would have thought that's all trauma.
She thinks she's probably not going to
Without
find
any-
someone
See,
she'd
it's-
like to.
We automatically.
We automatically
Go
think
to
it's
trauma.
Yeah, that's what I was,
But it's unclear, when I was studying.
I don't pick up that there's been
We
sexual
talked
trauma,
about that.
right?
Maybe
But she's
this relates back to what she said now. Did
she have
willingness and
leverage?
motivation?
she feels very irritable when someone says to her, "You could change. It could change. Would you like?" She's like,
Yes,
I'm
that's
sort of
different.
not-
That's different than her seeing what she wants to know about herself
Yeah.
and what she wants in her life. There are ways,
Ways
so
to-
really
yeah.
it's not about when somebody says to her, you can change, that's a judgment.
Yes.
That she doesn't want to be judged,
Judged, no.
but to
What does she
figure out
want
for herself
herself?
what she wants and how to get that, she can go to Betty Dotson, has a website with lots of information on it.
Betty Dodson.
DODSON. SON Betty, she's an old timer, yeah. Okay, so Rosemary Bassoon she really contributed a very big piece of work. She changed the sexual response cycle. She changed it to say, number one, it begins with willingness, and then it goes to arousal. She didn't say that desire was necessarily in it. It might or it might not be, but she said it's not linear, it's circular. and that desire could come up at any point in any phase of the sexual response cycle. It's not linear, and it begins with willingness. The other thing that she said is that, and that means responsive desire as opposed to spontaneous desire. And she said in order for responsive desire to be elicited, you need to look at the context of the situation, right? In other words, how long has it been since you last made love? What's the relationship like? What else is going on? What are stressors in your life? And you need to look at state of mind. Why do you want to have sex? Why don't you want to have sex? So, and that the goal of a sexual experience, she said, was not intercourse. Intercourse might contribute to pleasure and satisfaction, but the goal was to have the experience of pleasure and satisfaction, physical satisfaction. So this was a big, big shift. Now we're looking at a system. We're not looking at individual responsiveness.
So the goal was pleasure, experiences of pleasure and satisfaction.
Pleasure and
not-
satisfaction, but it doesn't have to include intercourse.
Oh.
And that was her, and she worked with women. Her research was on women, again in Canada. And now there's research going on to see if that holds true for men as well.
Who's the lady? Oh, that's still.
Rosemary Bassoon. So you see, there's the willingness to become receptive, right? To sexual stimuli with the appropriate context, whatever that is. If you have that, then you can move on to processing. You get subjective arousal, subjective arousal. So arousal, when we talk about arousal disorders, so for women, it's very interesting, and this connects to, you know, all this to do about the pink pill, right, the pink Viagra. It doesn't work. I mean, they're still doing research on
Is that
it.
for women?
For women.
Oh, never heard.
Because
There's the blue
there's a
and the pink.
difference between objective arousal and subjective arousal in women. In men, you can see arousal, it's objective, but women's feelings of being aroused don't always correlate. They say there's a 10% correlation between the feelings of being aroused and the actual physical signs of being aroused. So that's subjective arousal versus objective arousal for women. So now there's subjective arousal and responsive desire, and now you can move towards satisfaction in different ways. So that's her model. Now, there's another couple of models that don't change the sexual response cycle. We're pretty much, at this point in time, left with bassoons. However, they talk about what's operative in terms of desire. And they're based on Steve Porges's concept of neuroception. Are you familiar with Stephen Porges? Okay. So neuroception, the autonomic nervous system, is continually assessing safety or danger. So there's the dual control model of sexual response. And this actually, when you use this in a psychoeducational way, can be really effective. So the dual control model of sexual response says there are two systems. There's the sexual excitement system, which is the gas pedal, move and have sex. And there's the sexual inhibition system, the brake pedal, no. And they're both operative. Neuroception is operative in both at the same time. So it's assessing safety and danger at the same time. Now, depending, right, let's say, I'll tell you about a couple that this really made a difference for the wife. So there had been a lot of trouble in the marriage, lots of anger, it got worked out, but, you know, the residue was still there. And so when it came to making love, she didn't really want to, even though the marriage was functioning much, much better. She was still too angry. So one of the things that we worked on initially was if things didn't go just right in lovemaking, like the husband forgot something she told him pleasured her, or he moved too quickly, there wasn't enough foreplay, she would get angry. And to her it meant he wasn't being considerate of her. He only wanted to take care of his own needs. So the first thing that we worked on was, wait a minute, this happens. Normalizing it. This is not a catastrophe. This is something that happens. And when it happens, it's possible to say, let's just stop and talk about what happened.
Mm-hmm.
And then take two, start again, see how it can be different. So,
That's nice.
so that helped. And then in one session, I forget what we were talking about, and I said to her, you might be interested in this model. And I explained the model to her. And I explained to her, that, you pick up on all of these feelings and, whatever your senses pick up on and context of what's going on. And then you also pick up on, leftover upset, what might be dangerous. Now, she had nothing dangerous, but for somebody else it might be, I could pick up an STI, I could get pregnant. So for her it was more the negative feelings, and I said to her, and here's the story. It's really a choice. Both of these systems operate at the same time. So it's not just, I'm really turned on, let's move. It's not just going with the ons. It's also turning off the offs.
You're turning off.
And she really took that in. That spoke to her. And so, there's been research that's been done. Emily Nagoski wrote the book Come As You Are. And that's basically what she's describing is the dual control model and her research with rats in different contexts.
Rats.
Yeah. Which now generalizes to people, but okay.
Okay.
And, what she
It's the
found.
best psychological research. It really is.
What she
That's
found.
lucky
around
rats.
with
Okay.
But the same rat in a setting where there was lots of noise and electric shocks didn't get turned on sexually. But if you put with the partner, but if you put the rat into another box where there was low stress and food
Yeah.
and
Maybe a little
whatever,
wine.
and a little wine, right? That the rat got turned on. So that's what allows for sexual responsiveness: low stress, high affection, and high
And
trust.
how do you help someone turn off the offs?
That's a cognitive process, but you've
I mean,
done
yeah.
dynamic work before then,
Yes.
so they
yes.
have the experience of being able to.
tune in and.
Yeah. So there are different motivations to engage in sexual activity.
That system
Pleasure sex is the one that's ideal, right? You want to have pleasure, you want there to be eroticism, you want to be connected, attuned, all of that. What Peggy Klein-Platz, also out of Canada, calls optimal sexuality. But then you also have some women, right, with mikvah night,
Yeah.
are ambivalent about having sex on mikvah night.
This
It's
comes up all the
an
time.
Some husbands as well.
And some husbands,
husbands
thank
as
you,
well.
Yes, yes.
That was the case I brought in.
thank you.
Just like, I don't feel like it.
Well,
Obligations.
or the pressure around mikvah night for the husband and the wife wanting. I mean,
Right.
it goes both ways.
That's right,
The women who feel, how can somebody tell me when and why? It's like a-
right. Nobody's gonna tell me.
Right. Yep.
Right, and then Aileen Zoldbrod, who also has a website with a lot of information on it, and she's been in the field a long time, talks about mercy sex. You feel sorry for your partner. He wants to make love, you want it to be happy. But if that's what goes on all the time, eventually you're not gonna wanna make love, right? She says, when does the feeling of entrapment begin? That you have to work to reintroduce consent and choice and rebuild the sexual relationship.
All right.
right? You have narcissistic, friends with benefits, hookups, makeup sex can be great, but if you're always fighting and it's always makeup sex, that's not going to work so well after a while. And this is real what Perel talks about, for these couples that have these, they're working 23-hour a day and in their careers, planned sex. When you live with someone over time, she says, you have to will sex consciously. You have to decide we're going to have sex, we're in charge of our sex life. Sex is something you make happen, you willfully own the desire, versus spontaneity, where sex takes you over. So this is an example of that. It looks like I have a passionate moment open. Let's book it. So the next movement, this is where we are now, is optimal sexuality. And Peggy Klein-Platz and Steve Snyder and Nan Wise and others are part of this. And this really says, what's the focus of treatment? What are we really working with? Are we treating symptoms, sexual dysfunctions, pathology, fixing performance problems? Or should we be working with optimizing sexual potential, promoting sexual gratification, right? Snyder's his book, Love Worth Making, seeking more passion, intimacy, authenticity. Speak Ennis, be Ennis in sexual relationships.
Mm-hmm.
So she raises the question, when a couple comes into us with a problem, is it a sexual dysfunction or is it good judgment in light of the context?
Okay, so help me understand.
So if a woman is in a relationship where her husband doesn't treat her so well, she might not want to have sex with him. Is that a sexual function of desire disorder, or is it good judgment because he's not such a good partner? It's not an arousal disorder. So this is the new optimal sexuality thinking, and just mentioning that. And Peggy's done research on optimal sexuality that's very interesting. You can Google her, on the qualities that couples who have this great sex life say is present in order for them to have a great sex life. So, it's about valuing the partner, respecting the partner, feeling wanted, feeling taken care of. That when you have those qualities, feeling secure, trusting, then you can really allow yourself to go places when you're making life in different places together, and it becomes a more intense erotic experience.
I like because you enunciated the word authenticity, so you thought that to me that's
I think
something.
that's key.
Yeah.
Yeah.
I think it's real important.
So the DSM, I just wanted to say a few words about, people come in and they talk about erectile dysfunctions or, arousal dysfunctions, premature ejaculations, targeted late, now they're called late ejaculations, that kind, you know what they're talking about. So desire disorders are, the first, it used to be in the DSM-4 that hypoactive sexual desire disorder and arousal disorder were separate diagnoses for women. But in the new DSM-5, they're put together because some of the people who worked on it felt they belonged together. But not for men. For men, they're separate. And really what it is,
What are the two issues they put together?
a sexual desire disorder and arousal disorder, not getting, so desire disorder is, I don't have thoughts that turn me on, I don't have fantasies that turn me on, my partner wants to make love, I'm not interested, I just, I could go for the rest of my life and not have another sexual experience. That's a picture of a desire disorder. An arousal disorder is, similar to, although I don't know if it's part of asexuality, I just don't feel anything. Whereas, for men, it's about, I don't have fantasies, I don't have thoughts, I'm not turned on, I don't want to initiate, I don't want to be responsive to initiation.
Yeah, so it's interesting if a woman has the desire, she hasn't got a desire disorder, she has the
Arousal,
arousal, yeah. Or
So-
maybe they don't separate them anymore, so.
they don't separate them, right? I think it's a mistake, but
But you've seen that, people have one or the other.
where you have no desire, you're not going to have arousal.
But if you have desire.
You could, although you
she
could
has,
be
she has
turned.
desire, yeah, she has desire, but she doesn't feel, you know what I'm saying, she's like attracted to, it's weird, I don't know.
No, arousal is where you're getting excited. You've moved into the physiology where your heartbeat's beating faster. That's arousal. Desire is, I want.
Okay,
It's a
what
one
I'm
thing.
saying, she has desire, she has no arousal, that's what we're saying, what I'm saying.
About the woman
This
that you
woman
know.
does,
Yeah. Well, I don't hear that she has desire.
She
Where
has
does she have desire for
to
what?
romantically connect with someone, to be in a relationship.
Okay, but that's desire
That's
for
companionship.
intimacy.
Yes,
That's not
intimacy.
desire for sex.
Oh, sex, no, all right, okay, got it.
This is all
I'm
about
with you.
sexual desire.
Right,
Right.
right. So
Usually we think it's
So
Okay,
the
sorry.
thinking, there is some thinking that where you see male hypoactive sexual desire disorder, there's something else going on. Either
Yeah.
he's into porn, he's having an affair, there's something else going on. He's into drugs.
Kind of wonder.
So there's writings about that. For men, you have 3 orgasm disorders: premature ejaculation or early ejaculation. With delayed ejaculation, that's where it takes a phenomenal amount of time until he can orgasm.
Oh, what does that mean, phenomenal?
It could take an hour,
That's
more
a
than
lot.
an hour. The penis can be sore, and the understanding. Michael Perelman is the person who really is
I hear
on
that a lot
target
about.
with this, and he says it used to be thought that this was a personality disorder,
Really?
withholding person, but today we don't think that. In the field, retrograde is pretty rare. That's a medical condition. You'll have that diagnosed sometimes with infertility. That's where the semen, instead of coming out, goes back into the bladder. Or after prostate surgery, you have what you call dry orgasms. And you have to always think, how does this affect the relationship? Not just the person. What's the impact on the person? What's the impact on the spouse? What's the impact on the relationship? So the DSM-5 does not have pain disorders for men, but men do have pain disorders with ejaculation mostly, and that's usually related to overactivity of the pelvic floor muscles. So working with a pelvic floor therapist will help with
Because you
that.
usually think about that for women.
Yes, but for men also.
Okay, it's good
I
to
work
know.
with somebody who pelvic floor work helped him with this. And women, orgasm disorders are primarily vaginismus, where it's hard to have intercourse because the muscles in the first third of the vagina contract, that you can't get the penis in. And, we know how to work with that using dilators, but there's also a whole piece of psychological work
I think that was my client.
that accounts for that needs to be done. And then there's vulvodynia or vulvar vestibulitis, which is really a difficult condition to treat. There are some gynecologists who do surgery, the Goldsteins, Edwin, and I forget his brother. It's a nerve condition in the vulva, so they do surgery, which is often not effective and complicates things. But I want to share with you, I've only worked with 2 women with vulvodynia. Both women, when they began to work on the abuse in their background and their relationship with their husbands, it got incredibly better, and they were able to have intercourse again. So, in my experience,
What is
two
the
people.
what is the symptoms around that? I mean, you said
It's vulvodynia. There's either a burning pain on the vulva or a cutting pain. If you touch the vulva, it becomes like a tent. And it can take a while afterwards until the pain resolves. It's an awful condition. So let me just say about the medicalization of sex therapy, that, you know, drugs are a problem, right?
What kind of drug?
SSRIs,
Okay.
Yeah.
right? Depress libido, affect orgasm.
Yeah.
They can help if a man has premature ejaculation,
Yeah.
because they'll help him with that, so it's good. But often, you know, when it's used for depression, so it affects sexual responsiveness.
Yeah,
So
that's
then the
big.
doctor adds Wellbutrin, and there's a whole,
Big
It's-
reason,
it's a
lack
big
of
area.
compliance with
Well,
medication.
well, the lack of compliance here is less the issue than if the person is not doing sex therapy to figure out what's contributing to the dysfunction. It's gonna be a problem, but sometimes the medication itself creates the dysfunction. And so you always have to, when you're talking about medicine, you know, the Vialis, Cialis, Levitra, right? I mean, great drugs for a man who, you know, is older and has difficulties getting erection. They all work somewhat similar, but there are differences between them. But you have to look at the relationship piece, right? Couples become accustomed to living without sex. And, you know, when a man takes Viagra, sometimes his wife isn't so interested. So, you know, like this cartoon.
They had a whole thing of Viagra divorces, like men and
Yes.
things, and it just, when it first came out.
Really?
Do you remember that?
Yeah,
Yes.
Viagra divorces,
They
yeah.
were just, wow.
Yeah, for
That's-
disrupting the relationship.
Mhm.
Right. So here, you know, please doctor, will you prescribe a blue pill, he says to his doctor, and his wife has a sign in the background, right? Say no. You know, ups and downs for all of it. But always remembering that there's a psychological piece, a relational piece, that you have to know what this means. And then consultation and referral, right, where we have to have a referral source, urologist, gynecologist, psychiatrist, pelvic or physical therapies. And in the frum world, you'll always, well, not always, but often also working with Roberta.
Well, we want to thank you
Thank you so
so
much.
much, Rhonda, for coming.